Thank you for taking time from your busy day to watch this special presentation from the El Paso County Medical Society. I'm Dr. Joel Hendricks, President of the El Paso County Medical Society, and it is my hope that you will find our program of great interest, educational, and informative about the medical care provided by some of our best physicians in our country, right here in the borderland. From all of us at the El Paso County Medical Society, please enjoy tonight's program.
It's a condition that affects almost 12 million Americans. Dull, cramping pain in the legs, hips, thighs, calves, and buttocks. Numbness or tingling anywhere in the leg, the foot, or the toes. Changes in the skin temperature or color, and infections or sores that do not heal. All of these things could be some of the warning signs of peripheral artery or arterial disease, otherwise known as PAD. The arteries of the peripheral vascular system carry blood to the arms and the legs and the feet, but over time and with certain risk factors, clogged arteries can result from a buildup of fatty deposits or plaque that most commonly are found in the legs and the feet. Complications result in 150,000 amputations each year, and you do not want to get to that point, and we'll discuss that later. So there are some preventative factors that you can look into. The most important thing is to remember that this disease is easily detected, and it is more importantly, easily treated. You just need to find it out on time, get diagnosed, and get treatment. During the next hour, we have experts answering your questions about peripheral artery disease, again, arterial disease as well. And we want to thank Tenet Hospitals of Providence for bringing the show to you. We also want to thank the El Paso County Medical Society for bringing the show to you each and every month. I'm Catherine Berg, and you're tuned into the El Paso Physician. Thanks again for tuning in. We have a show tonight on peripheral arterial disease, PAD, and critical limb ischemia. And that's a mouthful, I know. We have two experts, one who's a veteran, and he's been with us for quite some time, Dr. Lake Araja, who is an interventional cardiologist and also an endovascular specialist. And we also have Dr. Ricardo Kostarakis, and he is the same title, again, interventional cardiologist and endovascular specialist. I know both of you kind of practice the same thing, but you have different specialties within that practice. And on that note, Dr. Raja, since you are the veteran, I'm going to ask you, how do you describe to the audience? We talked about your title, but what is it that you do all day, every day? When you're describing the endovascular specialist and interventional cardiologist in this world of peripheral arterial disease, how does that all play into that?
Very good question. So this peripheral vascular disease, which is, as you described, blockage developing in the legs and people losing their limbs. So to treat that, it's not only one specialty which is doing it. Actually, it's in a big evolution. It's going on. In the beginning, years ago, vascular surgeons were the one doing most of the vascular work, and which was mostly surgical bypasses. With time, everything is changing, and rather than having surgeries, things are done by endovascularly, like small catheters, balloons. So the recovery is quick, and patients stay less in the hospital. So interventional cardiologists, we are very, very trained doing all this wire and ballooning in the heart. So we have a basic skills built into us. So with time and with the need, like me, I started doing my practice 22 years ago in El Paso as an interventional cardiologist. And with need and with the interest, I started developing more and more skills into endovascularly, meaning treating patients with blocked arteries. Mm-hmm. The concept is the same, right. Blocked arteries in the heart or arteries in the legs. Mm-hmm. So many techniques, they kind of overlap each other. So interventional cardiologist means the cardiologist has been trained to treat the heart. Somebody has a heart attack, any kind of other things related to the heart, they treat them very well. Now, endovascular specialist is a part of it's not only interventional cardiologist, it could be a vascular surgeon who's trained with endovascular procedures or interventional radiologists. So these are the three main specialties who are doing this, and they call endovascular specialists. So in my practice, my practice is more endovascular than cardiology.
Oh, wow.
Right. This is because I wanted it to be that way. I have a very passion for what I do, and so peripheral vascular disease can be treated. So we want to identify ourselves who is more into this field than just cardiology.
So that is beautifully explained. So you don't have to say anything. I'm just kidding. No, but that's nicely explained, because you're looking at cardiology, everybody just thinks it's of the heart, period. And yes, there's the freeway system, and then the byway system, and this system, and that system, and you deal with all of that. Dr. Kosarakis, if you were to also explain what you do all day, every day, I know in complement to what Dr. Raja is talking about, how would you describe your role?
Very different from Dr. Raja.
Okay.
We are both interventional cardiologists, and we both have training in endovascular procedures. But in my practice, I see primarily coronary artery disease and about 20-30% peripheral arterial disease. But as Dr. Raja was mentioning, interventional cardiologists are traditionally trained in doing the same things we do in the legs, but in the coronaries, smaller arteries, a little more precise medicine. So we have training in the same type of tools. They're very similar, the ones we use for the heart and the ones we use for the leg, except that they're a little bigger and bulkier. So the training, there's a lot of overlap, but since there's been so many advances in interventional cardiology as all of medicine transitions to a less invasive approach, there's so many different things even within interventional cardiology that not all interventional cardiologists practice endovascular medicine.
Interesting.
Some
And that
just
makes sense.
some just specialize in coronary interventions. There are others that specialize in valve and structural interventions.
Okay.
And there are some that do a little bit of everything.
Okay. Nicely explained. That's great too, because that helps me direct different questions in different ways. What I'd like to do is start off relatively generically and plainly in describing what, and I know we've called it several different things. There's peripheral arterial disease, peripheral vascular disease. Are those interchangeable, number one? And number two, if you can describe what is happening in the body. When we call it a disease, it's something that is chronic. You know, sometimes there's things that are chronic but benign. This is not benign. This is something that can go forward unless it's treated. So if we can describe what that is to the audience so they understand what we're talking about. Does that make sense?
Sure, yes. Well, the peripheral vascular disease or peripheral arterial disease kind of overlap, but identifying exactly peripheral arterial disease is disease of the arteries.
Right.
So let me explain a little bit. So when the heart pumps the blood, clean blood goes to the entire body by arteries. So the clean blood gives oxygen to the entire body. But when the oxygen is utilized, the blood has to go back into the heart to go to the lungs to clean up. So it goes by the veins. So it's like a I-10.
Arteries out, veins in.
Yeah, so it's
Okay.
I-10. One is going this way, one is coming that way. They're next to each other, but they don't connect with each other. So if you're talking about the disease of both, so it's more like peripheral vascular disease. These
Okay.
are vessels, arteries and veins, they're all vessels, right? So, but if you're talking about just the arteries, then you call it peripheral arterial disease.
Okay.
So the symptoms of how it happens, it takes longer time, and if you look at the different risk factors, they are almost the same like coronary artery disease. What are those? Diabetes, which is if it's not very well controlled, high blood pressure, which is not very well controlled, your cholesterol is high, and particularly for peripheral arterial disease, if I have to really pick 2 or 3 main conditions which can lead to it, diabetes, smoking, and kidney disease.
So it's not that diabetes leads to this, the disease leads to diabetes for the most part.
No, diabetes leads
to.
Yes.
Okay. All right. So diabetes can be diagnosed way ahead of time. And so this is another risk factor, another outcome.
So
diabetes.
when we talk about preventive medicine,
Right.
So if the diabetes is very well controlled, you can really slow down the progression of peripheral vascular disease and coronary artery disease and others.
So here's a question, and Dr. Kosarakis, I love your name. Where's that from, by the way? You said you prefer to pronounce it in the Hispanic way, in the Spanish way. What name is that from? Completely off the subject, right?
It's Greek from the island of Crete. So the
Of
KIS ending is very characteristic
Kinda
of
thought
Greeks
so,
from
but I
Crete.
wasn't sure.
But I was raised in Mexico, so
Okay,
I grew
so
up
that's why
speaking
you said I
Spanish.
want to say the Spanish accent.
Right.
I love that. So Kosarakis, so I'd like to know, is this something that is genetic? So often we talk about cardiology, right? You're talking about coronary disease, arterial disease, et cetera. How much of it is genetic and how much of it is lifestyle? If it is genetic, can you help by lifestyle, et cetera, et cetera? Because I know we're going to get to amputations eventually.
Right.
So genetics, let's first start there. How much of this condition in both coronary and arterially and peripherally is it genetic?
It's the whole nature versus nurture, and we essentially don't know exactly. There's no specific gene that makes you develop atherosclerosis or peripheral arterial disease, but there are genetic conditions that cause lipid disorders or predispose patients to having type 1 or type 2 diabetes or other risk factors that will eventually lead to early arterial disease or atherosclerosis. So there's no specific gene. There have been studies where they look at even twins or next of kin, and they look at different risk profiles, and they'll separate their environments, or twins that were raised in different environments, they were adopted by different family members, and they'll look at their different lifestyles. Even if they have a high genetic risk, multiple family members with heart attacks or strokes, but their lifestyle is very different, your lifestyle can actually overcome your genetic risk in most cases. So there is that nature versus nurture theory, but it doesn't mean that because it's in your genes, you're going to get it for sure.
Bingo. And I so am glad that you said that, because I think some people think, well, I'm going to get it anyway. And on that note, again, a lot of what we do with this program is prevention. And if it's not prevention, it's early detection. So on that note, a risk factor is genetics, fine, a small one, but a risk factor. And Dr. Raja, can you talk about other risk factors? And then eventually we're going to go into, if you know you have a risk factor, how do you start countering those risk factors so that this may not get to a point where you do need an amputation?
Right. So one of the the biggest risk factor is uncontrolled diabetes. Diabetes, where the blood sugar is not utilized by the cells, and it creates so much inflammatory process, and it leads to multiple conditions, and which is coronary disease. If you really look into diabetes, there are few things this condition does. People who loses the kidneys, chronic kidney disease on dialysis, that's one of the main complications of diabetes. Losing eyesight, diabetic retinopathy is another one of the major things. Diabetes leads to blindness.
And that is vascular, is that correct?
Right. It's all related to uncontrolled diabetes.
Okay.
And third is coronary disease and peripheral vascular disease.
So dummy that down for me a little bit. So we're saying that is related vascularly. So what is happening when you have diabetes and you're losing your eyesight? What is happening to the vascular system? Is it just being constricted? Is there loss of blood flow, et cetera? Just if you pretend we have a model in front of us or a graph in front of us, and what is exactly physiologically happening when that goes down?
Diabetes creates a kind of a chronic inflammatory process in your bodies, in the vessels. The glucose sugar is not getting utilized appropriately by the cells, and all of this leads to collection and development of atherosclerosis. And you have the buildup of cholesterol in your vessel wall, causing blockage and clogs. Dr. Kostarakis, you want to add something?
Right. So the underlying disease is atherosclerosis. It's athero from fat. It's lipid deposits in the vessel walls. It can affect any artery in the body, arteries in the eyes, arteries in the brain, arteries in the heart, and the kidneys, then it eventually leads to peripheral arterial disease, coronary disease, retinal disease, blindness, strokes, renal failure, all those things. The way it affects the vessels is by forming those lipids, those plaques. The innermost layer of the arteries communicates with the bloodstream, and depending on the conditions, it can dilate or constrict to improve or decrease blood flow. When you have plaques, those areas that are covered in lipid or scar tissue or inflammatory cells are not communicating very well with the bloodstream, and it leads to what we call endovascular dysfunction first, which is usually abnormal vasoconstriction and eventually occlusion and blockage from disease progression.
Okay.
And so what we see at coronary disease, peripheral arterial disease, kidney failure, blindness are sort of the end complications of atherosclerosis.
Okay. So I want to get away from diabetes for a minute. I know we have a very, very large population base that has diabetes in town, in this area in general. But aside from diabetes, are there lifestyle changes, what exactly can people do if they know that they're at high risk, whether it's diabetes, genetics, or just that they know that their vascular system is compromised in whatever way? What is it that they can do to prevent further damage to their system?
So we call it, there are some risk factors you can do something, and there are certain risk factors you can't do anything, right? Like age. You're going to get old, you can't.
Whatever.
Yeah.
I'm learning how to stop that. Just want to let you know. No, but I get it. Yeah.
Right?
Yeah.
Or a part, as we talk about genetics, there are certain things you carried, not that much, but there are certain things which you do have a control over it. For example, high blood pressure, right? High blood pressure has same sort of effects on the organs if it's not well controlled, right? Second thing is smoking, right? So smoking is so much of a preventable condition, which also affects the heart, the kidneys, brain, stroke, heart attacks, and all that. Lifestyle, exercise, is one of the best thing you can do. Overweight, obesity, sedentary lifestyle, all of these things leads to you are not burning your fat, right? So this fat has to go somewhere, and that starts building in a simplest way, clogging your arteries, and you start developing all these conditions.
So when you say exercise, I think sometimes that scares people away. So it literally could be walking, right? And we could just start off with walking. And the reason I'm saying this is we have an audience, and that's something that's like, oh yeah, diet and exercise. So what does that mean to them? And again, we're looking at, this is basically a disease that affects, again, when we're talking about in the beginning, your feet, your legs, your knees, your buttocks, your thighs. So everything that's on the bottom part of you, if you simply get up and walk around, at least start with that. And feel free to compliment on that.
Yeah, so I think it's exercise. I like to separate. Walking is okay; it's better than nothing, but it's a very low bar.
Oh, look at
for
you! I like that.
most of us.
Good point. Yeah.
And Raja did this. I don't know if he did it consciously or not, but he separated sedentary behavior and exercise, because you could be sedentary and exercise 2 or 3 times a week, but then you go home and you turn on the TV and that's all you do.
Right.
So being active, walking around, walking to the grocery store if it's closed, walking your kids, going to the park, walking your dog, that's being active, avoiding sedentary behaviors. But then there's exercise. Exercise has the same purpose as not being sedentary, but I also use it as a warning sign. I tell patients, if you're gonna have problems with your vasculature, you're gonna notice it if you exercise. Your chest is gonna hurt if you exercise before it starts hurting when you're resting. Same thing with the legs.
Right. Good point. So a lot of people don't separate those two. So I appreciate you saying that. Very much. I'd like to talk about, so I know that there's a CLI program at Memorial, and I'd like to talk about what that is. So it's Critical Limb Ischemia Program. What exactly is that? And we can kind of talk about the program at Memorial from there as well.
Okay, so critical limb ischemia, it's if you start a condition 1, 2, 3, as it gets 3, 4, it gets worse and worse and worse. So like peripheral arterial disease, the first symptom is claudication. There's a term called, meaning that when you're walking, after walking a block or so, your calf starts kind of tiring and start hurting or cramping. You have to stop for a while and it goes away. So that's just like we call it Rutherford class 3 that among the definitions of it. That's because the arteries which takes the blood to your legs are narrowing, or some of them are blocked, but still you're getting enough blood that you're okay if you're not walking or all that. So,
And are they narrowing because of the buildup that's in the arteries?
Right,
Is that
yeah.
specifically why they're narrowing?
exactly.
Okay.
It's narrowing by the plaque.
Okay.
The fat build up into the arteries,
Okay.
or they're becoming hardening, their calcification developing.
And you're feeling it when you're walking because that's when the blood's going through.
Right. So when you're sitting down, your leg muscles, they don't need too much blood.
Right.
Right.
I get your point. Okay.
So when you're walking, your muscles, they need blood, and if the artery is narrowed, you're not getting enough blood. So suddenly you have a lack of blood, and the symptom of that is pain. It's just like when you walk and start having chest pain. That means one of your arteries of the heart is blocked. So you slow down, you stop, it goes away. Now take it to the extent where you have so much lack of blood to your feet that you start developing wounds.
Right. Okay.
You have, for example, diabetes is where one of the things in diabetes is a neuropathy. You start losing sensation on the feet. They kind of become numb, right? So it's very common that you have diabetes, you have a neuropathy, and you're walking barefoot at home and you hit something, a nail or something. You never felt it, or never felt it, right? So now you develop a tiny wound. Usually, within a week, just goes away. But if you don't have
Usually
blood,
if there's blood
yes,
that's supplying
right.
wound
So if
help.
right, so if you don't have blood, so then that wound is going to get bigger and bigger, and that's one of the main reasons you lose your limbs, right? So that is called critical limb ischemia. People who have a very advanced peripheral vascular disease, where the chances or risk of having a major amputation is very high. So in Memorial, we have developed a very strong program called Critical Limb Ischemia Program, which actually got accredited by Joint Commission. What does that mean? Is a big entity in this country which comes and sees what are we doing. Okay, there are different standards, and are we fulfilling all the standards? What are our outcomes? What is our amputation rate and all that? And then if they agree that we are doing what a center of excellence does, then they give you an accreditation. You'll be surprised to know that in the entire country of the United States, there are only 2 centers who have Center of Excellence by Joint Commission for Peripheral Arterial Disease.
And we have one here.
And Memorial
At
is one of them.
Way to go, Memorial.
Right.
Nice.
We show for the last, and we collect our own data.
Right.
And we have a committee. So this disease itself, you can stop me because I can keep talking.
No, this is good because I didn't know that before
Right.
coming here, so this is good to know.
So this condition itself,
Right.
critical limb ischemia, it needs more than one doctor, more than one person. Why? Because it needs somebody to diagnose it.
Right.
Somebody need to go and fix the circulation. It could be endovascularly, surgically, but that's a part of it. After that, if somebody has a wound, you need an infectious disease doctor to take care
Exactly,
to
right.
take care of the infection. You need a wound care physician to take care of the wound. You need a podiatrist if you need any sort of a minor amputation. So you need we call it a circle of care. So we have developed a CLI team. We have more than 10 different specialties working together. The whole purpose is how can we help this patient with very advanced disease to prevent amputation.
So when you say very advanced disease, give me an idea of what that means. So if you're looking at, and again, this is about prevention, right? So we're at a point where, and let's just say, to bring you into this discussion as well, let's just say there is a person has diabetes or they're feeling numbness in their feet, diabetes or not. And now there's a wound that's starting and the wound's not healing. And like many of us, we're like, oh, that'll fix itself eventually. And what I'm trying to get to here too is, when does somebody know when to go to the doctor? Because they know they have diabetes. Let's say they know this, and they know that it just takes a lot longer for things to heal. When do they know it's bad enough to go? And that is, to me, one of the biggest questions, where there are some people who are hypochondriacs and go right away. There's a large percentage of people that's like, how do you describe to a family member that you need your person to come in and get this checked out?
I would say anyone with risk factors, anyone that has diabetes, high blood pressure, smokers, strong family history, who has a wound anywhere in the lower extremity below the knee that worsens over a period of a week or two, or doesn't heal over a period of 3 to 4 weeks, that's signs that there's something wrong with either the healing process or the blood flow or oxygenation to that part of the leg. So anyone with any of those should have some kind of vascular study, ultrasound or some other type of screening study.
Okay, so let's now think that somebody is watching this at home and they don't know where to go. And is this something that they would go, and there's quite a few people in this town that don't have a primary doc, that don't have an internist. Should they go to the emergency room? Should they go to a clinic? Where should they go if they don't have a doctor already? And I know that's a tough question to throw out there, but when people are watching and listening, they're like, okay, yeah, sure, but now what? And then that's where the overwhelming portion comes in. It's like, well, I don't know what to do. I don't exactly know who to call. Can they call Memorial? Can they call this department? I mean, that's just a general question that the audience would like to know.
One of the benefits of having a CLI program is that there is always someone on call for the program. It's like having a heart attack doctor on call every day in the hospital. By having a CLI call team, means there's always going to be someone taking those patients at Memorial Hospital to diagnose the disease right away, how advanced it is, and whether the patient needs medical therapy only, an interventional procedure, or an amputation or some other type of therapy. So the CLI program is only at Memorial, so I would say if there's any concern, go to Memorial.
Okay.
But other ERs, other urgent care clinics, and primary care physicians can also refer. The word goes out there, but the Memorial is not the only one. There's other clinics that do similar types of procedures, but are not accredited for CLI management like Memorial is.
So that would lead me to my next transitional question of diagnosis. You're having these issues, you're having these problems, and how do you know what's going on? So how is it that you all diagnose and maybe it's someone who hasn't been diagnosed with diabetes yet, or et cetera, but they're having these issues. What is the process of scanning, diagnosing these patients?
Well, it starts with the symptoms.
Okay.
So it depends how advanced the condition is. It could be just achiness and heaviness on walking to an extent that you already have a wound, right? So usually what usually happens is, if someone develops a wound, they think it's problem with the foot and they go to a podiatrist, the foot doctor.
Right.
So actually foot doctors are kind of gatekeepers of peripheral arterial disease. It's just very interesting because patient, most of the time, they don't think they have a vascular problem. They think they have a toe problem. So first thing what we did, and obviously I think most of our podiatry colleagues, they know, is the education of how a wound on the toe is related to a poor circulation. So usually what happens is a patient shows up either in the hospital or in the podiatrist. First thing they think is they check the pulses, check, and then think, oh, there's no pulse. So they call the physicians, like CLI specialists, we call them. And so what we do is then we start our workup, for example, examining where the pulse is, the poor pulses and sensations and all. And then there's some basic, simple tests available. For example, ankle brachial index is just like checking a blood pressure in the ankle and the arm. Let's say your blood pressure in the arm is 120 or 80, and ankle is 50/30.
Oh my, right.
So
Good
why
point.
it's so low is because there's some blocked arteries not letting the blood go down to the foot. So that right away tells you something is not correct. So then you can go in detail developing a sonogram. So sonogram is you kind of looking at those arteries and see, oh, there's a blockage here, and it and eventually the gold standard is an angiogram, which is putting a catheter and taking pictures of all the arteries, where they start and where they end, how long is the blockage, and then the
So
decision.
describe that if you don't mind. So the angiogram, what are they? They're putting a catheter into the groin, into the artery in the groin.
Right.
Because I find this fascinating that you can do this. So describe how that test is done.
So angiogram is, we don't use much groin anymore.
Okay.
We use wrist.
Oh, wow.
It's
Okay.
because it's
I've been doing this for too long.
no.
All the new stuff, yes.
Last time when I came, and now
Yeah.
there's so much change.
Oh my goodness. Yeah.
For good, better change.
Right.
So one of the issues used to be that, going to the groin, it can bleed, cause
Yeah.
hematoma. So this is much more secure, easily controlled bleeding and all.
Okay.
So when the heart pumps blood, it pumps the blood all over. So all the arteries, they're connected to the heart, right?
Right.
So
It's
they're
all
interconnected with
centralized.
each other, right?
Yeah.
So you can put a catheter from here and go all the way down to the legs.
See, now I'm just thinking your limbs there's so much more room to get to from here to
Yeah.
the heart versus the groin to the heart. But
We have
again, it's all
long
the-
catheters.
We have long catheters.
We have
Like
long
my
catheters.
gorilla arms. Yeah. Okay.
So then we go all the way down to the aorta and down into the arteries, and we can go all the way down to the knee and take pictures all the way down to the toes.
Wow.
And
Okay.
it gives you a beautiful picture of what's happening, right?
Yeah.
Because all these other tests like ABIs or sonogram, they are not 100% sure.
Right.
You can miss something. So that's once you do an angiogram, you know exactly how severe is the disease, and then depending upon that, you make a decision how kind of a treatment procedure he or she needs.
That is a perfect transition into treatment, right? So now we see that there are things wrong. Going into treatments now, and that will lead to amputations when and if they're needed. So treatment plans for different people. I know everybody's different, every case study is different, but give me some case studies or some ideas of treatments that go on from there.
The treatment really depends on so the disease is a spectrum, so it depends on how far advanced you are in the disease spectrum, those are your available therapies. When we talk about CLI, that's sort of the end stage of peripheral arterial disease. Those patients usually need interventions. They have complete blockages, usually more than one artery of the leg. So they need some form of intervention. But you can start treating the disease in the beginning stages when it's just early atherosclerosis. So early stages, asymptomatic, but with signs of buildup, you treat with aspirin, cholesterol medicine, and what we call risk factor modification, controlling the diabetes, controlling the blood pressure, controlling the cholesterol levels, and exercise, good diet, and avoiding sedentary lifestyles. The more advanced you are in the disease and the later you catch it, the worse the blockages are going to get.
Right.
We sort of separate CLI from claudication because patients with claudication usually have severe blockages, but not usually complete blockages. Patients with wounds from arterial disease will have complete blockages, so the treatment is a little different. But most times, the first step is to do the angiogram, diagnose the severity and the location of the disease, and some kind of endovascular procedure. That means balloon angioplasty, putting tiny balloons crossing the blockages with little wires. I explain to patients they're like the strings in a piano. They go in from the wrist or from the groin. You cross the blockages with that tiny wire. You use that wire as the tracks on a train, and over those tracks, you advance tiny balloons or stents if needed to
So this
open
is
the
going
blockage
into the vascular system.
inside of the artery, from either the
And that
wrist or the
fascinates me
groin.
because your arteries have to be pretty strong to be able to handle that. I mean, it's
They're pretty sturdy.
Okay,
You have to
okay.
have I like to think we have some degree of finesse.
Right.
But they,
I like to think that we have some degree of finesse.
but they are
As
pretty
surgeons,
sturdy.
yeah.
A lot of these
Yeah.
arteries are heavily calcified. Sometimes you can see the artery without injecting, and it looks like almost like bone, like thin bone,
Right.
because there's
And
so
are you
much.
able to take that out while in this process? Or I know you're opening it up, but are you, I don't know if that's even a possibility. Are you able to take some of this plaque? and
It's one of the
calcification out?
therapies. Once you figure out exactly what's making up the plaque, if it's calcium, if it's mostly just fat, there's different devices. We call them atherectomy, and the whole idea is to what we call debulk. So you're trying to take as much of the stuff out of the artery before you balloon or put a stent into it.
So that's interesting to me, because I always think about coronary. I know this is not peripheral, but coronary artery disease, when you go into the neck, is that a possibility to do in the neck arteries as well?
Yeah, it's done.
Okay.
Stents. Most commonly is surgeons will do an endarterectomy where they'll actually open it and clean it. But if the patient is not a surgical candidate, they'll put a stent in there.
Okay.
They don't usually do debulking or atherectomy because pieces will go to the brain.
Oh, goodness,
If tiny
right, that makes
pieces
perfect sense,
go
yeah.
down in the leg, we have special filters. They do have them in the brain too, but the risk is much higher in the brain than it is in a couple of toes. But that's one of the things we do before we do atherectomy. We use specialized filters that'll catch little debris from going down to the distal leg.
Okay. And so when you're talking about these off breaks, I think we often use the word just clot when we think about strokes or whatever. So that would be designated a clot, so to speak, right? And going, see, this is, yes, finesse
Yeah, it's-
is a good point. So now let's talk about a point where a person is getting to the point where they're going to have some kind of an amputation. And I'd like to kind of start with toe amputation, then foot amputation, and then going up from there. Does that usually and always start with a wound that won't heal? Does it start with, like you said, there's a lack of blood flow, a lack of oxygen to whatever limb? And I'm just throwing out to either Dr. Raj or Dr. Kostarakis, whoever wants to take that first. And feel free to kind of piggyback on each other too.
Okay. Well, let me talk a little bit about amputation and then get a little more detail about this amputation.
Okay.
As you were telling the statistics about the 150,000 amputations are done every year in this country. And if you look at those amputation of 150,000, how many of those patients really had the angiogram, what we are talking about, or some kind of intervention?
Something done earlier than getting to the point of amputation.
No, before, if somebody shows up with a wound or a toe gangrene, 70 to 80% of the patients, they go directly to amputation without even trying to figuring out, maybe I can save this leg. I'm talking about nationally and internationally.
And
Some
is that
people,
at
they
the
think, I hope this is old thinking, but it's still there. Many people, they think, including doctors, that if someone has gangrene of the toe, if you amputate the toe, you are done with the problem.
But you're
right?
not.
So that's wrong. Why? If you look at the statistics of people who have major amputation, meaning below the knee amputations, 25% are dead within a year, and 50% of them are dead within 3 years. Worse than breast cancer and a colon cancer, right? So this is just a little bit about amputation. Amputation is the last thing you should ever think of.
So bottom line is it's not the answer.
It's not amputation.
It's not the answer.
Absolutely is not the answer. So having said that, so if someone has, let's say, a wound on the great toe, big toe of the foot, the problem is not the toe. Problem is the entire leg.
And
Right?
the circulation to the leg.
Yeah, circulation could be blocked above the knee, below the knee, right? So there was a concept, and there is a concept now that, well, I'm diabetic. Well, I'm going to lose my toe, and eventually I'm going to lose half my foot, and I'm going to lose all my leg. Why? Because nobody ever fixed the circulation, which is the bottom line problem.
Right.
Right?
Right.
So when we see these patients with a toe is black, it's a gangrene, Of course, the toe is no more alive and needs to be amputated. But what I'm thinking is, how can I save the rest of the leg? Because you can have amputated toe, and you have a good blood flow, and it heals, and you can wear the same shoes and have a normal life, right? But if you are not treated correctly, then eventually you're going to lose the entire leg.
Right. Exactly.
So this is the concept of critical limb ischemia program, that we have these policies built in, that if you see somebody with this, okay, first thing is angiogram, where is the disease? Let's get together, all of us, and figure out how can we best treat that. And if you do that, like in our Memorial Critical Limb Ischemia program, our amputation rate, major amputation, is 5%. Nationally is 15 to 17%.
Oh, my.
Yes.
Okay. So I'm going to go back to, because I think it bears repeating, the treatment measures. So we are, again, you're finding patients who are not at risk. I mean, they're full-blown in the disease, and then treatment of them not getting to the point of amputation. Again, walk me through that, unless I'm not getting it. So we're talking about these interventional, you're going in, you're opening up the arteries, you're opening up the vascular system. Is that the treatment? And how good is that? So we're talking about stents that are going in there. Do those last forever? Do those last for several years? Does a patient come back and check on it later? Or is that only done because they're having more symptoms? That's where I'm trying to find out. It's like, once you know you've got this problem, you want to avoid the amputation, what are all the steps that are being taken to get to that point?
So this is Dr. Raja explained, it's a multi-specialty approach. And the part that I do and Dr. Raja does is the sort of the revascularization process, but also the continuous follow-up once you open the blockage. The mentality when we're treating patients with CLI, it's the whole life or limb mentality from old warfare and emergency medicine. Anything that's going to risk a limb or your life, we should go all in against that and try to treat it. So the first step is to revascularize. And we sort of take a similar stepwise approach. The first thing you do is the most simple, the less risky, which is balloon angioplasty. And when we're revascularizing the legs, perfection is not what we're looking for. Like when we're revascularizing the arteries in the heart, you want to make sure that the residual blockage is zero in the heart.
Exactly.
And the legs is a little different. The outcomes we're looking for are, one, wound healing, and second, amputation prevention. So you may restore blood flow and have a not perfect result, but as long as you avoid amputation and heal the wound, the patient can reocclude the same artery, and as long as they don't
That's my
develop any
question.
wounds, they
Yes.
may not need other interventions.
Okay.
So that's where the continuity of care comes in, because more than 50% of patients that have a peripheral vascular intervention will have reocclusion within 3 to 5 years. That's changed based on the different techniques and technologies that have been developed in the last few years, but they need a continuity of care. They need medical therapy, aspirin, Plavix,
medications.
statins, but
Okay.
also anticoagulants at low doses. The stent is sort of reserved as a last resort, because once you put metal in the artery, the risk of forming blockages actually goes up. So we leave it as a last resort once the other therapies fail. In the last few years, special balloons that have a medical coating on them have been developed, and the results are promising. So the risk of what we call restenosis or reocclusion has been decreasing over time.
So the balloon stays in.
No, the balloon is
Balloon
used
goes
temporarily,
in, stretches it out, and then comes
stretched,
out?
and then comes out.
Okay.
Those medicine-coated balloons stay there for about 4 or 5 minutes, and then it comes down, but that always comes out. The stent stays
So
in.
whatever vascular entity it is ballooning, how long does that stretching last? Does that make, so if you're going in, you're stretching out that area, because I know people have their esophagus stretched, and like once every 2 or 3 years they have to go in and have it stretched again because they've got a hernia or whatever. Is that the same with the vascular system? That it's just something you have to stay on top of? And that's where do the symptoms come in order for them to say, okay, I might have to have this done again? And I
Right.
guess that's done through sonograms at that point too, right? The diagnosis of that?
So this disease what we are doing, we are not curing, right?
Right. And that's,
So-
you know what, I didn't say that right. So this is chronic. This is
Yeah.
something you have for a
Yeah,
lifetime.
this
It's just a
disease
matter of
there
treating
is
it
no
and getting
cure
through
to
it.
it. There's no cure to it. But if we can prevent amputation for 10 years,
Right.
I mean, that's great. Don't you
Absolutely.
think?
Absolutely.
So any sort of a treatment, what we do, you're talking about stretching. So yes, stretching. If you is full of plaque and you go and you just push with a balloon, the artery is going to open, and 50% of the time it's just going to recoil because plaque has to go somewhere.
Right, exactly,
So
right.
that's why we have atherectomy, where we shave off all the plaque, so that we removing all these plaques. So now that there is much less plaque in the artery, the lumen is bigger. But again, we are worried about that this tissue is going to grow again.
Right.
So we use drug-coated balloons.
And in the shaving of the plaque, is that also what we were talking about earlier, that you're worried that some of that might fall off, or so that's part of the...
Correct. So we call it distal protection device or distal embolization.
Okay.
So you sort of cutting this, and no matter how great the device is, because you have so much plaque,
Right.
a part of that can break loose. So then we protect it.
So when you
remove
say
it.
shaving off, and I'm just trying to follow through in my head how this is working, you're shaving off some of that plaque, and with the stent or the tools that you're using, does it suck in the plaque
Right.
out immediately as you're shaving?
So there's
Just
a
trying to be
device.
mechanical about it. Does that
Right.
make sense?
So there are different devices. One of the
Right.
devices is that there's a blade cutter, and underneath there's this much is a nose cone, which is like of a packing. So every time you cut, you pack inside that cone, nose cone. So when that's full, you remove it and you take the plaque out.
See, next time we do this, throw
I
a
can bring
video,
some-
throw
yeah.
a video our way.
Okay,
Yeah, that
okay.
would really bring. I love the toys. I got to tell you, because you can see what's going on. It helps me with my knucklehead brain to understand what's going on. But a video or two, would be fantastic.
You'll be amazed how much advancement in peripheral vascular diseases happened for the last 10 years.
I'm already amazed, because I'm already talking, even just now, not going through the groin anymore.
Yeah.
I mean, how long has the wrist been more of the option versus the groin? Has that been the last 10 years? 5
Been
years?
about 10, 15 years.
Jeez Louise. Okay.
It started in the coronary space, and
Right.
patients that went to the hospital with heart attacks. When people started using the wrist, the mortality for the heart attack actually decreased from a decrease in bleeding complications, less risk of hematoma, pseudoaneurysms, blood transfusions, something so simple. But because the artery in the groin is easier to access, it's bigger, you can put bigger devices in it. That's what we use for 10, 20, 30 years.
Right, exactly. So another nice transition is the future. Where are we going now? I mean, we're looking at, the differences from 10 or 15 years ago. Where do you see us 10 or 15 years from now? And we're kind of at like that 10-minute mark in the program anyway. So I like to know about advances, and I also would like to throw out to both of you, if there's something we haven't talked about yet that we really want to get across this evening, to kind of have that in the back of your head to talk about before we close up. But what do you see as advances in the next decade or so?
From the endovascular standpoint, obviously, I don't think there is any patient, we could call it, we can't do anything for you. So that's the first thing. Okay, anybody who goes to any physician and is told, well, there's nothing can be done and you need amputation, they need to have absolutely second opinion, and they
Right.
look for physicians who are doing this.
Come seek you out. There's something you can do.
Yes,
for sure.
yes. There's
Okay.
a lot of difference in different places. So from that standpoint, there are different procedures are getting developed. One of them, which actually I'm part of this, is called deep vein arterialization procedure. What does that mean is that people with critical ischemia, the one with the wounds and gangrenes, about 10 to 15% of them, they have absolutely no arteries. It's just got blocked, with calcified, and they don't exist anymore.
Oh, they don't exist anymore.
Yeah, you cannot find them.
Jeez.
We call
okay.
them desert foot.
So
it's
the,
like a
the
desert.
body just kind of
It's just
engulfs them,
calcified,
just starts.
and they become like threads.
Wow.
And
okay.
those patients are like 100% major amputations.
Right.
So a few years ago, there's a new concept developed that how about each artery, as I was saying, is next to the vein. The artery goes this way, vein goes that way, but they're close together. So the concept is how about we connect the artery to the vein and convert the vein into artery.
Oh, wow. So you're converting it.
You're converting the artery
Right.
to the vein, so the vein now actually taking not
Blood to
only
the-
the unoxygenated blood, but oxygenated blood opposite direction to the foot.
Okay.
So there are multiple different clinical trials. Recently, in New England Journal of Medicine, PROMISE 2 trial was published, which shows about 70%, 6 months amputation-free survival. I mean, 70% of the people, they didn't have amputation when they were all 100% were scheduled to have amputation. And I'm very thankful to Memorial that now we are part of that clinical trial, third phase trial. So we are bringing the technology to Memorial Hospital because this is not available anywhere else. These are non-option
Yeah,
patients.
2 in the country, you said.
Yes.
That's impressive.
So that's one of the advantage of being,
Yeah.
center of excellence.
Right.
So I see in the future, surgical, endovascular, all sort of new technique. Every time you go to a conference, you just get amazed. New catheters, new wires, new this. It's like an explosion.
Yeah. It's like a field trip every time.
Yeah.
So one of the doctors described that. It's like it's a field trip and we're buying stuff.
My
No.
wife says that for me, it's going to the Disneyland.
Oh, I bet.
Yeah.
I bet it is. And every year you don't know what's going to be. So the rides are different every time.
That's right.
I like that. I like that. Is there anything that we haven't talked about yet that you'd like to get across or anything that you want to add about what you foresee in the future?
Yeah, I think awareness. One, awareness about the diagnosis, how to identify the disease, the different screening studies and options. An ABI is covered by every single insurance. It's easy to do, it's non-invasive, and I think every patient should have one during their annual exams. But also, which physicians' specialties to refer and when, so that patients know their treatment options. A lot of times they're referred to one specialty and that specialist says there's nothing to do, and then the patient thinks there's no options. So I think awareness about the different treatment options and different specialists that provide that type of care is also very important. And there's a huge lack of awareness about that, even within the same specialty within other cardiologists, about what interventional cardiologists do in the peripheral space.
So I have a question on a normal general person who is not in the field of medicine. And you know how Dr. Google works, right? Is there a website or a place that you would like to send people? And I do want to say this too, with the El Paso County Medical Society, if there's a question that you all have by watching this, and I know that this is airing and you're like, okay, it's over, but if you can email your question to info@EPCMS, so the El Paso County Medical Society, epcms.com, regarding peripheral artery disease, if it's something that we didn't hear about this evening or something that you heard and want to have an answer to, email a question there, because in the next show, we'll be able to answer them for you, because we're going to take a little bit of each show from the previous show and answer some of those questions. On the point of online questioning now, you can go to Google, but it's Google. I do a lot of my research on WebMD. With this particular situation, is there a cardiology website that you like to point people to educate themselves or not? I just thought I'd throw that out because you were talking about information and informing yourself. How would you have patients do that before getting to you? But at the same time, you don't want them coming up with all this stuff saying, this is what I've got. You know, there's a fine line. Right?
Yeah, so WebMD is a good start, but it'll usually end up referring you to some kind of doctor 100% of the time.
Yeah, and that's my question, not
Right.
for it to be an advertisement.
If it's more for, I want to learn about this disease and what are my options, I think the American College of Cardiology, acc.org website has a patient section where there's a bunch of different topics, and they talk about diagnosis, prognosis, management options. There's also the Society of Cardiac Angiography and Interventions.
Say that slowly.
SCAI, Society of Cardiac Angiography and Interventions. There's
Okay.
also a patient section there, and this is more specific for interventions, what type of options are there for patients. But the American College of Cardiology is usually the main one that I use for patient resources.
Okay, and I'll repeat those, and also I'll give you a way to watch the show again, but that's acc.org is one of them. Again, acc.org. Another one is scai.org, scai.org. On that note, too, if you are just watching this and you would like to watch it again, or there are some other things that you have questions about, there are several places you can do that. You can do pbselpaso.org and just look for local programs, and you'll find the El Paso Physician on there. You can also go to the El Paso County Medical Society website. That's EPCMS. Just think of El Paso County Medical Society.com. And then also, and again, you'll find the program on there just through the logo. And then YouTube. So YouTube is one of those easy ones. Everybody's got YouTube, and you can do youtube.com and just look up the word the El Paso Physician, the El Paso Physician. And the great thing about looking it up that way is that I was talking to Dr. Kotaraskis earlier, and I said, because you watched a couple of cardiology shows before coming here, and I said, well, how exactly did you find them? Because people find them in different ways. But you went to pbs.org, and it took to KCOS, and then you looked up cardiology, and it showed you all the different shows in the area of cardiology. You can do that with whatever type of program we have. So, but again, if you have a question regarding this show, talk to or ask via an email, info@epcms.com. But I want to thank you very much. Again, we've had Dr. Lake Raja with us, who, and I will say it again, interventional cardiologist and endovascular specialist, because that's a mouthful and a half, and thank you for explaining
Thank
what
you
that
very much.
is. And Dr. Ricardo Costarukais, see, I did it wrong at the last. Costarakis. It's actually Greek,
There
but
we
we're
go.
making it Spanish. Why not? And we'll do it that way. But you have been watching the El Paso Physician. Thank you for tuning in. I'm Catherine Berg. Good night.